Welcome everyone to the October 27th session of the WHO COVID-19 Vaccination Costing, Financing, Budgeting and Delivery Learning Series. Today's session, which is the 13th session in the series, will focus on Mini-cPIE COVID-19 vaccination interaction reviews with some regional perspectives and lessons learned. Welcome to everyone and thank you for joining. My name is Bruce Strumminger and I'm with Project ECHO. It's our pleasure to be supporting this series and I'll be running through some housekeeping and logistic issues. Next slide. First, we have interpretation in French and Spanish. So please take advantage of that opportunity by clicking on the interpretation button, the small globe at the bottom right of the Zoom toolbar. Choose the language you'd like to hear. And if you only want to hear the interpretation, click on the mute original audio selection. Next slide. We really look forward to your questions and comments today about this exciting topic, about these Mini-cPIE examples. Please put your questions and comments in the Q&A feature at the bottom right of the Zoom toolbar. They're just to the left of the interpretation icon. We'll be scanning that feature and looking out for your questions and comments. If you have any questions about IT issues or logistics or the certificate of attendance, please put those in the chat and we'll try to answer them as best we can. Next slide. We are offering a live transcription, closed captioning in English, and you can access that by clicking on the live transcript icon. It's actually between the Q&A and the interpretation icons, and then just select Show Subtitle, and you'll be able to see closed caption subtitles in English. Next slide. We are recording today's session as we've been recording all the sessions in this series. Your attendance is consent to be recorded. Thank you for that. We'll be sharing the recordings of the session along with all the PowerPoint presentations after the session, and we'll share a link to the TechNet 21 website that supports this series, as well as another website so you can access these through those options. The recordings will be in English, French, and Spanish. We'll also be giving certificates of attendance. Those are through the University of New Mexico, where Project ECHO is based. About 15 minutes before the end of today's session, we'll share a link in the chat. And after you take a brief anonymous survey, will take about 3 to 4 minutes, you'll be able to receive an instant certificate of attendance. We really appreciate your feedback, so please take advantage of that opportunity. Next slide. Just a note about data. We take data stewardship very seriously, and all the data you share with us when you registered through the chat and the Q&A, we guard that data very carefully, and what's shared with our partners at WHO is all de-identified. Next slide. With that, it's my pleasure to hand over the microphone to Jenny Waldorf with WHO to formally welcome us, and she'll be moderating today's session. Jenny.
Good morning, afternoon, evening, everyone. Thanks so much for joining this session. We'll hear global and regional experiences with Mini-cPIE. If we go to the next slide, we will start with some announcements. You can take a look at the recent publications on the WHO COVID-19 Vaccine Introduction Toolkit site at the link here. There's guidance on freeze preventative vaccine carriers there. Also, the COVID-19 vaccine Janssen training video is up. You also have the opportunity to look at the new global vaccination strategy that was presented on October 7th by the UN General Secretary and the Director General, WHO Director General, and also highlights from the recent SAGE meeting that includes recommendations on additional dose for immunocompromised persons, and lastly, the Boost Listening and Learning podcast. Next slide. Here you have the upcoming October-December 2021 sessions for this costing, budgeting, financing, service delivery series. And the top one is our session today. Next slide. So getting into the agenda for our session today, I'm going to start and give you an update on global Mini-cPIE implementation around the world. And then we have 3 great presentations, one from our Europe regional office and one from our Africa regional office, where we'll hear about experiences with vaccination interaction reviews, or Mini-cPIEs, or adaptations of those activities in those 2 regions. And then we'll have a presentation on analysis of reported global Mini-cPIE findings that our colleagues from MMGH will present. And for each of those presentations, we'll have an opportunity for 5 minutes of clarifying Q&A on the presentations themselves after each one. And then at the end, we'll have 20 minutes for a panel discussion with our regional COVID-19 vaccination focal points and of course the presenters. Next slide. So I'll go over the goal and learning objectives for this session. So the goal is to share and discuss regional Mini-cPIE, otherwise known as the Vaccination Interaction Review, or IAR, experiences and strategies for global synthesis and analysis of findings. And learning objectives, we'll understand the methods currently being used for COVID-19 vaccination rollout reviews, talk about the effective adaptations that regions have used, adaptations to the standard Mini-cPIE methodology, and then lastly, understanding methods for analysis of the Mini-cPIE findings, limitations to that analysis, and how it can be applied at the global, regional, and country levels. And so next slide. So this slide shows the current status of Mini-cPIE implementation in the different regions globally. You can see which countries in green have already conducted either a Mini-cPIE or a variation on the Mini-cPIE methodology. You'll note that in Euro, we have a number of countries who have conducted a review that is an adaptation of Mini-cPIE, and we'll hear more about that in the next presentation from Euro. And also here we have those planning to conduct a Mini-cPIE and those countries with interest. So it's really great to see that we have so many countries who have conducted a review and many others that are considering conducting reviews. Next slide. So with that, I'll go ahead and introduce our first presenter, who's Dr. Roberta Pastori from the BPI unit in WHO Europe office. Thank you so much for being with us today, and I'll hand over to you.
Thank you for the opportunity to participate to this meeting, and good afternoon, everyone. I will briefly introduce the current approach used by Euro to review progress in COVID-19 vaccination, which is mainly focusing on use of data for action. So next slide, please. So first of all, the situation in the region is quite variable across countries. So all of the countries, all of the 54 countries and territories in Euro region have started a COVID-19 vaccination, but at different timing. And overall, the region has reached 51% uptake with a complete vaccine series. But there is a high variability, not just across countries, but across a group of countries defined by income. So in the high income countries, definitely there is the highest uptake uptake with 64%. And in the upper middle income countries, we reach 38% uptake. And in the low and lower middle income countries, we have 17% uptake. So the variability is quite high. But overall, the region has followed the recommendation of SAGE and ETAGE in terms of prioritization of groups of population. So the uptake is higher in the oldest age group, defined as 60 years and above. Next, please. So when we look at how the region is performing in terms of achievement of globally set target for COVID-19 vaccination, we have 96% of the countries that reached the least ambitious targets of 10% uptake in the total population by end of September. So only 2 countries missed this target and they are both belonging to middle income countries. Next, please. However, when we project how countries are likely to perform towards reaching the 40% uptake by the end of this year, we see that there is expectation that all of the high-income countries will reach this target, but less than 50% of the middle-income countries are expected to reach this target. Next. So if we look to the more ambitious target of 70% by mid-2022, the expectation is that even a lesser number of countries will achieve this target, including 20% of high-income countries are expected not to achieve these 70%. Next, please. So one of the reasons why the projections are showing challenges in reaching the especially 70% uptake among the total population is that in the region we have a group of countries that are let's say driving the high uptake, and they are high performing countries. But then in the middle part of this very busy graph, there is possible to spot several countries that are actually having a good progression in terms of uptake up to 30–40%, and then they are plateauing, so progressing very, very slowly towards higher uptake levels. And then there is a group of countries that are really struggling in keeping up with the uptake, so they are having a very low uptake compared to the regional mean. Next, please. Another challenge in the European region is that even for countries that are achieving a relatively high general uptake, the distribution of the uptake by age group is not always reflecting the recommendation from SAGE and ETAGE. Especially in the middle income countries, the countries are struggling to achieve a good enough uptake in the most vulnerable population. So in people aged 60 and above, and especially in the 2 groups of 70 plus, 70, 79 and 80 plus, that are really driving the severe morbidity and mortality. Next. So recognizing that there are challenges in the region, of course, we have engaged countries in reviewing their progress in COVID-19 vaccination. And besides some very regular touch base with countries that are facing the highest level of challenge, we have engaged in one by one, let's say, in-depth review of the progress. However, for the vaccine pillar, the Mini-cPIE and interaction review guidelines are not broadly used. They've been used occasionally. So the region has opted for a slightly different approach. And the rationale for this choice is that we have seen that really the situation is very rapidly changing in terms of access to vaccine supply, in scaling up the service delivery capacity, and there is a lot of variability over time in terms of demand from the total population or specific target groups. And in the few countries that conducted a more systematic review using the Mini-cPIE and EIR approach, we noticed that by the time that recommendations were agreed, findings were consolidated, and recommendations were issued, some of the recommendations were already outdated. So we opted to a kind of faster approach. And another reason for opting for a lighter approach and faster approach is that in the WHO Europe region, a lot of the countries are middle-income countries, so they do benefit for a lesser support from partners, so that there is a higher workload on the national government staff. And plus, the WHO has really a small footprint at the country level, which makes it difficult to organize coordinated activities at country level, including field visits. And also we noticed that most of the countries in the region were able to collect a lot of information to enable the monitoring of COVID-19 vaccination, but there was a limited use of available data. Next, please. So the approach of the European region is to really have some data-driven discussion with national stakeholders and key partners. And the main focus of those discussions is to agree to, of course, identify the main challenges in that specific point in time and agree on a few very pragmatic and timely action points that can be carried over directly by the national governments or with the support of partners. So these discussions are useful to identify areas that need support from WHO and partners, but in a very operational terms and for immediate follow-up. And also with this approach, we agree with the countries to have a first touch base with this data-driven discussion and then follow up quite closely in 1-2 months after the first touch base to check the progresses and how needs have been changed. Next, please. So the overall process is that at the regional level, we monitor also together with UNICEF and other partners the progress of countries. So we identify countries with the lowest uptake and plateauing uptake over time. So we prioritize those and engage them to have this data-driven discussion. And of course, we respond to direct requests of support from countries. This data-driven consultation is quite quick, is basically about 2 hours virtual consultation with key stakeholders. And the key stakeholders includes, of course, the Ministry of Health and its agencies, but often we have been engaging with representatives from other ministries and agencies that do support the COVID vaccination rollout. It's always part of this consultation, of course, the representation of WHO regional office and country offices, but also other key partners that, of course, are specific depending on which countries are engaged. The level of engagement in these discussions have been different depending on the countries and perceived main issues. So we had a consultation with countries, including the ministries of different of the Ministry of Health and other ministries. We had also some countries involving the Prime Minister himself or herself, and other countries that just focused on engaging the technical level. So it's really depending on the country context. The preparation for this consultation is mainly driven by the WHO regional office. So based on data that are submitted on weekly and monthly basis by the countries and special studies that are coordinated by WHO, we do analyze data that are already available in the regional office. So the demand on the countries is very limited in terms of preparation. And we share this analysis with the countries, and of course the countries can complement with data that are not shared with WHO. And the discussion is kept quite informal, and it's really a discussion around the slides presented with analyzed data. Overall, the preparation and the report writing and agreement on follow-up action is taking a couple of days. Next, please. So far we have completed this data-driven discussion, data-driven review with 8 countries, which are mainly middle-income countries, but also a couple of high-income countries. And we have a planned review with 5 countries and possibly an additional 3. Next, please. So the data that we are using during this data-driven review are data on vaccination uptake, on vaccine utilization, on some key indicators on immunization system performance, and data available on demand. And next, please. So the data that we present, that we use to engage countries in this data-driven discussion are the overall trend in uptake compared to the regional mean. Next, please. The weekly uptake to see how the vaccination is progressing week by week and by vaccine dose. Next, please. And then the vaccine utilization. Here in this slide, I'm just presenting overall vaccine utilization, but we do have data by product-specific utilization, which is quite useful to understand if there is a problem with utilization of one specific vaccine product. So those are examples of two different types of countries. One that has been progressing quite fast in terms of uptake following the regional trend, and then has been plateauing. And consequently, the vaccine utilization has been decreasing over time. The country on the bottom is another type of country that had issues with vaccine supply at the beginning of the campaign, and then had a rapid scale up of the uptake, and due to challenges in accessing the vaccine, fall back to very high vaccine utilization and decrease in the weekly uptake for the first dose. Prioritizing the completion of the vaccination in those already reached with the first dose. Next, please. Then beside these overall trends in vaccine uptake, we also look at age-specific uptake, both in terms of trends in the country to see if the most vulnerable age groups are being reached as they should, and we compare the country performance with the regional mean. And we do also present, when available, uptake data among healthcare workers, which is of course a priority group, not just as a recipient of the vaccine, but as promoter of the vaccination. Next. So based on the vaccine uptake and utilization in the most recent weeks, we do categorize countries with using an analytical quadrant. And this categorization of countries is helpful to guide the discussion to identify the underlying reasons for either a low vaccine uptake or low vaccine utilization, or both low vaccine uptake and low vaccine utilization. Next, please. So the assessment of the underlying issues is mainly pointing to common causes that are vaccine supply. So in terms of access to vaccine or oversupply, so poor capacity to utilize the vaccine supply. And then issues with the service delivery, both for the general population or specific age groups, access to vaccination services for the population, and issues related to demand for vaccination. And of course, there are also, this is also an opportunity to check data quality issues that can affect the quality monitoring of progress in vaccination. We use also data reported from through the EGRF COVID module on monthly basis by countries to understand what's the setup of the country in terms of adherence to global recommendations and overall organization of the immunization campaign. Next, please. So we look also at data available through behavioral insight surveys or through qualitative research that have been conducted in countries either on the general population or specific target groups. So we look at trends in intention to vaccinate, reasons for hesitancy, and other parameters that may be available depending on what type of a study has been conducted. Next, please. So another thing that is presented to countries is the projections of their performance in reaching, or their likelihood in, to reach the global targets of 40% and 70% uptake by end of 2021 and mid 2022. So these projections are helpful to really understand the urgency of actions to accelerate progresses. Next, please. So through this exercise with countries, the main issues that have been identified and the main areas of support that have been identified are related with suitable implementation of suitable strategies to reach priority target groups and effective engagement of healthcare workers, which proved to be a challenging target group in some of the countries, and there is a lot of support that is provided in targeted training for healthcare workers or activities to engage them effectively in promoting COVID-19 vaccination and get vaccinated. Then there are issues on effective engagement of national stakeholders, which can be either government sectors outside of the health sector or partners that can help in the implementation, especially at the community level. One issue that has been identified in European countries is the predictable access to vaccine supply. So not so much the access to vaccine per se, but the predictability of when vaccine doses will be available, which products will be available, and what will be the shelf life of the products received. Of course, there are a number of challenges related with demand for vaccine and identification of effective strategies to increase demand. And one issue is also the availability of data for decision makers. There is a lot of data available in the countries, not always compiled in a way that can be used effectively to drive the decision-making process. And another issue is that several countries have implemented a lot of initiatives to increase the uptake, but there is a little assessment of the impact of those initiatives. Another request from countries is to access to examples or best practice from countries that successfully addressed some of the common challenges. Next, please. So to conclude, the future plans in terms of helping countries in reviewing their progress is that we are drafting a guidance on how to conduct an in-depth analysis and summarizing this review approach that we use from the regional level. And this guidance is mainly for the in-country use. We are continuing with this engagement of countries at least until the end of this year, and we are following up with the countries that have been already engaged once. But we have as planned to consolidate the findings from this, let's say, revised approach in the region, and also understand what are the outputs and outcome to understand if it's a good enough approach to support countries effectively. And that's that's the last slide from my side. Thank you for your attention.
Thanks so much, Roberta. So we have just a couple minutes. We can take some questions on your presentation. It's really great to hear the methods that you're using in Euro, the idea of having a really light approach that allows quick response to the findings is great. If those in the audience would like to pose questions, please use the Q&A panel on the bottom of your screen. There's one question that has come in asking about why high-income countries are not using the CPIE or the IAR platform for review, and perhaps the question could be posed in your region. You showed the various countries that you have worked with on this type of review, and a couple of them were high income, but primarily middle income and low income countries. Are you aware of different methods that high income countries are using to review the rollout, or is it just that they're not working directly with the WHO office on it?
Well, first of all, in the region, the high-income countries are performing quite well, the majority of them. So they don't have really a huge need to review their progresses and address challenges. But some of the high-income countries have been engaged. For example, Lithuania and Poland, they have been engaged in this exercise because they were having the perception of clear challenges that would have benefit from the support of partners. But the majority of high-income countries do not engage that much in this exercise, either because they are already performing well, so they don't really need this type of support, or because they have a national capacity. And they also there are other ways to review the progresses and share experiences. For example, for the high-income countries in the European region, there are a lot of networks related with the infrastructure available through the European Union. So countries can get together to share best practice, good experiences, and is a continuous learning process that is facilitating by an underlying structure is already existing. And WHO is engaged in those forums. So we do share our guidelines and recommendations. So some countries are using the similar Mini-cPIE approach by themselves without support.
Thank you. One other question has come up, asking where, this is from Tensime Hansi, where are the data available? I think the question's asking about the findings. Are they available?
Data is available because we have so this approach is really based on the fact that at regional office, a lot of data is reported. So we can offer to the countries the support of analyzing the data in a standard way, based on what countries are reporting on weekly basis in terms of progress in uptake. So there is a quite complete reporting from countries, 52 of the 54 countries and territories in the region are reporting regularly data on weekly uptake and weekly vaccine supply. And plus we have 50% of the countries that report quite regularly on monthly basis program indicators through the EGRF COVID module. So there is a wealth of data already available at the regional office that is summarized and shared with the country. What we usually miss is the subnational uptake data. So this is something that countries that have this information readily available complement.
Great. And so last question is where countries in your region find helpful resources. I know you mentioned you're preparing guidance on this process. Any other resources you would suggest?
Resources on this process, no, as I said, we are working on this guidance. We have shared with all of the countries a kind of PowerPoint presentation with the proof of concept of this approach. And this has been broadly shared with all the countries. That's why some countries directly reached out to us to have this data-driven review. But yeah, there is no resource, let's say, publicly available yet.
Thanks so much, Roberta. I think in the interest of time, we're going to move into our next presentation, and we'll have a bit more time at the end for open discussion. So next, I'll introduce Dr. Sheila Sasirwe to present experiences with the Mini-cPIE from the Africa region. So I'll hand over to you, Sheila.
Hello, everyone. I'll be sharing some experiences from the Africa region, from the IARs that have been conducted so far. And most of these learnings are from the IARs that were conducted following the initial rollout process. So most of the lessons were in the early phases of rollout activities. Next slide. So far we have, as of today, the countries that have conducted IARs in the Afro region 23, but as at 15th, when this presentation was prepared, there were 21. But as of today, there are 23 countries that have conducted their IARs or Mini-cPIEs. Next slide, please. And unlike Europe, for Africa region, most of the countries use the IAR or the Mini-cPIE methodology as per the guidance provided. And most of them used a blend of physical and virtual workshops to analyze program data and field reports. And in these workshops, they had plenary presentations from different discussions on thematic subgroups. And the thematic subgroups were guided by trigger questions, which were in the guiding documents for conducting the IARs. Next slide. So from the IARs, or from the countries that have conducted IARs, it's hard to find themes that are cutting across all the different reports, because most of our country experiences are really specific to countries and different contexts. So, but we tried to pick out examples of countries and also themes which were appearing in most of the IAR reports from the countries that have conducted the IARs. And for instance, under planning and coordination, what has worked well, we've seen that most countries noted that involvement of the NITAGs and other high-level engagement of different bodies in the countries helped to push the rollout process and get buy-in from the high level stakeholders. Then also involvement of local partners and subnational level structures ensured that there was ownership at all the different levels, and this made planning and coordination. The countries planned as one unit, and the rollout made the rollout process easier once all the levels were involved in the planning and rollout processes. And then also we noted that using previous experiences in rolling out massive campaigns or rolling out new vaccines in the context of different epidemics helped the countries to quickly adapt and also roll out the COVID-19 vaccines in the countries using this experience. And then flexibility in implementation of the NDVPs. Most countries are constantly readjusting their plans and including targets, geographical coverage, different strategies, because we'll note that we've had a challenge with erratic global vaccine supply, and because of the uncertainties of not being sure when these vaccines are coming and how much they will be getting, it's been challenging. And so countries have to wait for the vaccines to arrive, and then they quickly adjust their plans. They cannot really plan properly because they don't have adequate information on how many vaccines they will receive in what period. And so that also became a challenge. Prioritization of groups based on vulnerability, business continuity, and national security, in addition to a SAGE prioritization roadmap. So most countries had to add in other different priority groups in addition to the SAGE prioritized groups, in order for them to be able to open their economies or to make sure that their security is safeguarded. Next slide, please. Again, as I already mentioned, the erratic global vaccine supply leading to inadequate vaccines causes challenges, is still causing challenges to coordination and planning, because there's a lot of uncertainty and they don't know how much resources to plan for, or how much time they need to implement a campaign. So they just have to wait for the vaccines to be allocated. And also the delivery schedule. Sometimes countries receive information that they've been allocated doses, but these doses arrive, they don't know when the doses are arriving. And sometimes there are delays in delivery. Even when they reach the country, they reach the countries when they have short expiry dates. So challenges with delivery schedules and coupled with short timelines for deployment have caused challenges to countries, because when there are delays and the vaccines reach in the countries with less than a month to expire, countries have to implement the campaign in emergency mode to try and avert expiries, which causes a lot of strain on their systems. Then we also noted that most of them at the beginning had challenges with funding, because most of them were relying on external funding. They could not raise adequate funds internally and had to rely on external funds, which could also not be immediately acquired, or had to take long processes to acquire those funds. So it caused a lot of challenges in the middle. Teams were frustrated because they had no funds, but along the way, some of these have been addressed. But from the early implementation phases, these are the challenges that we saw coming out. And then introduction of multiple vaccines within a short time, yet these vaccines all have different requirements, also caused a challenge to some of the countries. Next slide. Regarding training, what are some of the things that have worked well? Adapting virtual platforms or blended training approaches using online courses, webinars, combining physical and virtual trainings to ensure that health workers are equipped with adequate knowledge. As you can see, some country examples: Ethiopia, they used mixed strategies for training health workers. That was both virtual and physical. And then South Sudan, where they only used registered nurses and clinical officers. This was mainly to build confidence in the communities, because communities know that these health workers are well-trained and competent. Next slide. Some of the challenges, as I already mentioned, funding was a major challenge, which affected most of the sub-themes. And also the simulation exercise tools were not used because the vaccines had already been rolled out. Some countries, for instance, in Ghana, we saw where some parts of the country have poor internet connectivity, and so virtual trainings could not work, or they had a lot of challenges with those trainings, and health workers ended up not being adequately trained. And then South Sudan, they had challenges with delayed funding. Even when they had planned for the trainings, the funds were delayed. So we find that most of the health workers were not adequately trained as earlier planned. Next slide. Regarding vaccine and cold chain logistics, past API investments in cold chain came in handy. Most of the countries had functional cold chain capacity to handle vaccines that did not require special ultra cold chain conditions. And so most of the countries were able to roll out vaccination using these vaccines that didn't have special requirements, because they already have some infrastructure in place for the routine API activities. And then also monitoring and maintenance of a cold chain to the requirements were similar for the COVID-19 vaccines as other routine vaccines. So it helped that these systems were already in place. Next slide. Next, so these are some country examples using vaccine accountability tools in South Sudan. Ethiopia, they used reverse logistics system to try and avert expiries. When they noticed any doses that were nearing expiry, they always used reverse logistics to channel them to areas with high demand. And in Ghana, we saw innovations of using drones to deliver vaccines to hard-to-reach areas. And Senegal, they used real-time monitoring of stock using Logistimo software, which helped them to avoid expiries, but also monitor stocks in real time. Next, please. This picture shows someone in Ghana who was preparing vaccines that were delivered by drones to one of the hard-to-reach areas. Next slide. Some of the challenges for the vaccines and cold chain logistics. Most of these vaccines have short expiry dates, and some of them, as I already mentioned, sometimes there are delays in delivering these vaccines after allocation, and so they arrive in the countries with a very short expiry of maybe 1 month or even less. And for instance, in Liberia and DRC, they received certain shipments which had less than a month to expire. And then countries had to struggle and make sure that those doses are utilized before expiries, and some of them end up expiring. So that has also been a challenge. And then distribution of the very limited vaccine doses stretches resources, because the doses come in very small quantities, and they can't wait for other batches. They have to be pushed out immediately, which really is not very efficient, because if at least big quantities were being rolled out, it would reduce on some of the overhead costs and try to utilize the little available resources. But because they come in small quantities with short expiry dates, they have to be pushed out immediately, however small the consignment is. And then shortage of ultra cold chain equipment. Most of the countries didn't have ultra cold chain equipment, although most of them are in the process of acquiring these. But even these, you find most of them are at central level, and then at subnational level, they don't have the cold chain equipment. So most of them tend to deploy the vaccines around the central level stores, where they can easily give out those vaccines that require ultra cold chain equipment. Those are some country examples. Gambia, Eswatini, where they had inadequate funds for transportation of fuel, and South Sudan, where they reported irregular reporting of stock levels, which makes it hard to monitor stock status, especially if you're monitoring uptake, but also vaccines which are about to expire. Next slide. So what worked well, as I already mentioned, experience with conducting previous mass vaccination campaigns came in handy for most of the countries, and also using multifaceted and flexible delivery strategies. So most countries have been adapting their strategies as they go along, because most times they have the guidance, but they have to modify the guidance to suit the prevailing circumstances, especially when they are faced with expiries, when they are faced with low uptake or hesitancy. So they keep on adjusting their strategies, adjusting the priority groups to suit the prevailing circumstances. Sometimes they have a shortage of vaccines. We've seen some countries where they've had to do match and mix because of shortage of one type of vaccines, and people needed their second doses. And so even if their initial guidance was to maintain one type of vaccines for the 2-dose series, most of them had to adjust along the way, depending on prevailing circumstances. And then the initial slow start helped to build capacity and confidence of the health workers, because most of the rollout processes were really slow. Most of the health workers were able to gain confidence and be able to understand how to manage the processes. Next slide, please. These are some examples. Countries have had to adapt, for instance, conducting outreaches to high volume traffic sites, then vaccination of special populations, organizing special campaigns to vaccinate special groups, which are essential maybe to the economy or vulnerability, or as I already mentioned, security of the country. And then installation of vaccination sites in some of the, we've seen in DRC where they had to set up vaccination sites in some of those centers where they were targeting some of their priority groups. Next slide. Uncertainty of vaccine supplies continues to be a challenge. And then challenges to balance COVID-19 vaccination activities and routine immunizations. Health workers who are doing COVID-19 vaccination are the same health workers that have been doing and are doing routine immunization activities. So most of them burn out. They are working very long hours under pressure to utilize doses in the country. So most of them are really burnt out. Next slide, please.
Sorry to interrupt, Sheila. We're running a bit behind schedule. If you could try to wrap up in the next minute or two, that would be great.
Oh, sure. Right. Risk communication, some countries, what worked well, countries used different influencers to engage communities, social listening exercises, social media. So they use different strategies to reach the communities and address emerging challenges. Again, most of the countries adapted different strategies as they moved along based on what was emerging from the communities. Next slide. Those are some country examples. I can skip that. Next slide. Again, these are some country examples. Next slide. Monitoring and evaluation. Electronic data capture and use of real-time visualization dashboards helped most countries to keep tabs on how the rollout was going and adapt accordingly to be able to have an effective campaign. So those are again some country examples. We see Ghana use of QR codes for verification of persons vaccinated being affixed on vaccination cards, and then hiring of extra personnel to handle the extra data requirements at the different levels. Next slide. These are just, can skip that, next slide. Some of the challenges with monitoring and evaluation, inadequate support supervision for the data teams and leading to poor data quality, but also lack of devices and data bundles to handle data in real time or submit data in real time. And then slow registration processes, which were causing overcrowding at vaccination posts. Next slide. Regulation, safety, and AI5, we've seen what worked well, most countries involved national regulatory bodies early enough in the processes. And also AI5 and safety was given high attention in trainings and system designs. Those are some country examples. Next slide. Some of the challenges included uncoordinated AI5 surveillance activities and also multiple AFI reporting channels in some of the countries, but also inadequate support supervision to emphasize the need for AFI surveillance at all the different levels. Next slide, please. So following the interaction reviews or mini-cPIEs, countries are trying to institutionalize best practices identified through the exercises and also address challenges or bottlenecks identified. Next slide. This is my last slide. And we've noted that for IARs, most of them are really context specific, and the action points and recommendations mostly benefit the countries that conduct the IARs, although other countries can also learn from the different experiences. And we are following up with countries to monitor implementation of their recommendations and also using the findings from the IARs to update their NDVPs and operational plans. We've had different platforms where countries have shared experiences and lessons learned from the IARs that have been conducted. We've had Ghana, Uganda that have shared experiences in previous Mini-cPIE clinics. We've had different countries sharing experiences through webinars. We have microsite as Africa Regional Office, where different countries continue to share emerging lessons from the IARs they conduct, and also working with partners to identify areas that they can support, where they can provide support to countries to identify, to support the identified bottlenecks. And currently, Africa Regional Office is conducting support missions to countries to identify bottlenecks that have been identified through the IARs. Thank you. That's it from the Afro region.
Thanks so much, Dr. Sisirwe. That was a lot of really rich information about lessons learned in the countries in Afro. And I just wanted to mention that the microsite that you've launched for Afro is really great and allows individuals to look at lessons learned and view which countries have found which lessons. And so it might make sense to put the information about the microsite in the chat for the audience. In the interest of time, we may need to move to the next session, given that I don't see any questions currently. Well, here we can let's take one question and then we'll move on. There's a question in the chat about the use of drones. You mentioned that there was one country who had used drones. Has that been used more widely than can you remind us which country was using drones for delivery of vaccines?
That was Ghana.
Has it been used elsewhere?
Not that I know of.
Okay, thanks. All right, we're going to move to the next presentation. Feel free to continue to put questions in the Q&A, and perhaps, Sheila, you can always respond within the Q&A while we're moving on to hear about analysis. So Dr. Thomas Cherian from MMGH is going to tell us about qualitative analysis of Mini-cPIE reports that they are working on. We're working closely with MMGH on implementation issues with countries. And so it'd be really great to hear the progress that you're making on analysis. Thanks so much, Thomas.
Thanks, Jenny. If we can go on to the next slide. And the next one. Yeah, so basically, I think this analysis builds on what Sheila just presented in terms of the data that they have extracted from the Mini-cPIE reports from the countries in the region. So the objectives of this analysis was really to pilot the use of a qualitative analysis software, which is MaxQDA, to sort of compare the outputs from the simple thematic analysis that Sheila just presented, and to see whether we could create a sort of a narrative that would maybe at least better inform stakeholders at the global and regional levels to better understand what the operational challenges were and what the underlying reasons were, so that they could better tailor the support to countries accordingly. So in this analysis, for the preliminary analysis, we only focused on the challenges that, or the operational challenges that the countries faced. We wanted to document what the benefits and limitations of doing this analysis, which is purely based on the Mini-cPIE reports, and then to use the results to see how we can define the future use of the qualitative analysis, and perhaps also see whether there is scope for improvement of the Mini-cPIE tools. Next slide. So using this software, our first step was to code and subcode the interaction review reports. So for this process, we initially, a few of us independently coded a select number of IAR reports, which started with just 2, just to harmonize our coding. Then we compared and consolidated all the codes that we used and used those findings to create a common code book that would allow standardized coding by multiple coders. Next slide. So as a result, we had 8 main codes, and these were based on the NDVP categories. And then we had 20 high-level cross-cutting codes with around 115 subcodes. We analyzed only 6 IAR reports for this pilot analysis. And can we have the next slide? And this is just to give you a snapshot or a screenshot of what the software looks like and how we code it. So on the left-hand side, you can see the codes, and for financing, you can see the subcodes. And on the right-hand side, you can see the Mini-cPIE report with each of the areas coded and subcoded according to the codes that we had generated. You can see from the reports that the reports themselves are mainly in bullet points, and they are fairly high level. Next slide. Of course, we can generate frequencies with which these codes appear and create word clouds, as is shown in this thing. But this doesn't necessarily mean that what's coming out as most prominent. You can see training, coordination structures, electronic tools are coming out most prominently, but this doesn't necessarily mean that what features very prominently is necessarily the most important issue in the reports themselves. Next slide. So we wanted to dig a little bit deeper and then, as I said, try to create a narrative and maybe get a better understanding of what some of the potential root causes were. Next slide. So we used this using this sort of analytic framework. So we started with what is the desired outcome. The desired outcome is a high uptake in utilization of the available doses, which is what Roberta mentioned in the first analysis. So that is a commonality between their analysis and what we attempted to do. Then we looked at some of the key themes in terms of the challenges that countries were facing in achieving their desired outcomes, and then use the subcodes within these themes to maybe create a narrative and get a better understanding of what are the issues that underlie these key challenges along these 3 thematic areas. Next slide. So based on the frequency with which these were occurring among the challenges, we came up with these 3 potential common themes that seem to recur across the Mini-cPIE reports that we analyzed. One was the knowledge and capacity gaps of the personnel involved in rolling out the vaccines. The second was the inadequacy of plans, of the operational plans themselves. And the third was unavailability of funds. And of course, this intuitively made sense because we know that in able to implement any program, you need to have an adequate plan, you need to have adequate financial resources, and you need to have a trained health workforce to be able to do that. So using these 3 thematic areas, we then tried to look at some of the underlying issues using the subcodes. Next slide. And we created this sort of fishbone analysis. So this is the fishbone analysis for the first of these thematic areas, which is the knowledge and capacity gaps of the health workforce. And then we classified this along these 5 different areas, which was the process, the budget and financing, information availability and quality, the human resources, and the training tools. And then we pulled out the main issues or the subcodes that were recurring in each of these areas to create the sort of fishbone analysis. So you can see that the delays or inadequate budget release was influencing the knowledge and capacity gaps, the lack of budgets dedicated to specific areas, for example, training of the data managers, as you have seen in the presentation by Sheila. There were inadequate training materials, for example, or the lack of full information about the vaccine characteristics, which were contributing to knowledge and capacity gaps. The training tools themselves and the training methodologies. And again, you heard some of this in Sheila's presentation from the Afro Mini-cPIEs. And then, of course, the delayed and inadequate deployment, the inability to retain the people who were trained, and process issues. And I'm not going to go over each of these in details because these slides will be shared. So in a sense, we were trying to do this fishbone analysis to create a sort of a narrative into what were the underlying issues around the main operational challenges that countries were facing. Can I have the next slide? And again, I'm not going to read through this, but in this slide, what you see is in each of those 5 areas, we can link what we said or what we summarized very briefly to the actual bullet points in the reports themselves. So these are actually verbatim reports from the IAR reports that you saw in each of these different areas in that fishbone analysis. Next slide. So this is similarly the fishbone analysis for the inadequacy or the planning tools and resources. And again, once again, these are divided in those 5 areas that I mentioned in the previous analysis. And for the sake of time, again, I'm not going to go into detail into each of these areas, but these slides will be distributed so you can see what we came up with. And our intention is mainly to give you a snapshot of what is possible using this sort of a qualitative analysis tool. Next slide. And this is the similar analysis for the unavailability of funds. Next slide. So what were, in our view from our pilot, the benefits and limitations of the analysis? The benefits were that the coding system allowed us to create a narrative using the subcodes and maybe better delineate some of the contributing factors that led to some of the key implementation challenges. One of the things that we could improve on is to weight each of these contributing factors, and perhaps we could use the frequency with which the subcodes occurred to weight the contributing factors to give an indication on their relative contribution to the operational challenges that were faced. And of course, we think that these outputs could be used to both promote cross-country learning, and as I said, perhaps for the regional and global stakeholders to get a better understanding of the underlying issues and tailor their support to countries accordingly. There are, of course, several limitations. I mentioned one of these before. So in general, the IAR reports themselves only provide a fairly high-level view. And we know that underlying those high-level view in the reports and that was the result of a lot of detailed discussions that took place over a period of 2 or 3 days, but those were not always captured in the IAR reports. And as you saw, many of them were in sort of bullet format. The second limitation, of course, is that the individual country learning, as was mentioned earlier, may be context specific. They may only apply to certain countries and may not apply to other countries. And when we sort of combine the findings from different countries to draw out common themes. Next slide. I think that's my last slide. Next slide. Yeah, so maybe we can pause for a few minutes before and see if anyone has any questions before, so that we have some time for a discussion to follow.
Again, if you have any questions, you can put them in the Q&A panel. And we can always move on if there are not specific questions about the analysis.
Yeah, I think there is I see one question is, what is the current COVID vaccination rates as compared to the target fixed by COVAX? Maybe I can address that. So I don't think COVAX has fixed a target. WHO has certainly, in the global strategy, proposed certain targets. These still need to be taken within the country context because we know that the population demographics vary considerably between the countries. But it is very variable, both between regions, between countries in each region, and perhaps also within a country between different parts of the country and different population groups. So, for example, in the African region, I think the coverage, the proportion of the population that is fully vaccinated is less than 5%. It's much higher, say in European region, in high-income countries, it may be close to 50%. So it's very heterogeneous, both in terms of the number of countries that are on track to meeting the targets, as well as on the average coverage across the region.
The next question, to what extent do African countries react and adjust their policies? And this is an important question in terms of the implementation and actions taken as a result of the mini-cPIEs. That might be a question for Sheila. Sheila, are you there?
Okay, maybe I can answer on her behalf. I think in Sheila's slide, she did indicate, so after the country conducts an IAR, they do generate a list of prioritized actions and stratify them with those actions that require an immediate change, both at the strategic level as well as the operational level, and those that need to be addressed in a medium term. But of course, this is not an end in itself. I think there has to be a close monitoring of how these policy changes are then influencing the rollout of vaccines and the effect to which they are making a difference. And I know in the African region, this is being followed up by country missions where teams of experts are going to individual countries and then sitting with them to go over the main challenges that they're facing and supporting them in updating their operational plans, as well as developing a coordinated and tailored partner support plan.
So maybe this is a good time to move to the broader discussion. I just wanted to mention that we have some, as part of our panel with regional representatives, we have Alba Maria Ropero from the Americas in the Pajo region, as well as Emmanuel Tondo from the Ciro region, who have joined along with our presenters from Afro and Euro. So we have a few different perspectives globally. We can move to the next slide, and I'll hand back to Thomas to moderate the panel discussion.
Okay, thanks again, Jenny. So maybe can we go on to the next slide? So I think during this session, you have heard about 3 different approaches that have been used. And the main objectives of each of the approaches that has been used is to enable countries to learn early lessons and then adapt their operational plans to ensure that the delivery of vaccination is optimized. So I think from the European region, you used an approach where they used the data for action approach, which used both the quantitative data as well as some of the qualitative data from their behavioral and social drivers surveys and other assessments to then support countries in doing in trying to respond to these. And in the second, can I have the next slide, please? I'm not sure who's operating the slides. Can we have the next slide? Okay, it doesn't seem to be coming. So I think, so let me start this panel discussion and just to say that then in the second presentation you heard from Afro, where they did the classical Mini-cPIEs and then sort of summarized the findings across the regions. And in the third presentation, we just showed you of maybe a further use of qualitative analysis of the reports themselves to create a little bit of a narrative. And so as a first question, wanted to understand or get the feedback from the regional level is what are the relative merits and limitations of the different approaches that we have presented in informing the future operational planning at the country level. And maybe you can, consider this question along each of the 3 levels, the global, regional, and country level. So to get your insights, and I'll start with Alba Maria, if she would want to, having listened to the 3 presentations, have any comments. Alba Maria, over to you. Are you on the call still? Jenny, do we have, I can see Alba Maria is on the call, but she's...
Alba Maria, if you're there, you're muted. Maybe we should...
Can we unmute her from...
She's sent a message saying she has an issue with her microphone. Perhaps we should go to...
Okay, let's, I wanted to give the chance to the regions who have not presented to go first. So Emmanuel, if you are able to unmute and maybe provide some.
Yes, thank you very much. Thomas, can you hear me?
Yes, loud and clear. Please go ahead.
Okay, great. So first, I thank the presenters from the other regions, and thank you for this qualitative analysis also done. So my immediate reaction listening to that is I have the impression that these different approaches are more or less complementary, and I will explain what the colleagues in Europe have presented using data for action. I think we can identify with that, if this region can identify with that approach, and possibly other regions also in following up the data that is coming from the country. The colleague in Europe mentioned some variables that they are following up and bringing out indicators. So these are the same kind of variables that we are following at the regional level. And at this level, we are also writing a weekly publication of what is observed from the data that is coming from the countries. I'm talking like vaccine uptake, coverages among different target groups, and so on. So it looks like some of these data for action can be used at the country level. It can be used at the regional level, that is for sure. Now, the IR itself, of course, is an activity that must be done at the country level. What our Afro colleague has presented is like a compilation of the area that is done. So right now in our region, we have one country that has completed an IR, another one is conducting that and should be completing that shortly, and others are planning to do so. It looks logical that after a certain number of countries have completed, you have to synthesize this and bring out some common themes and make some recommendations that could be common to the countries or could be specific to the country. So that is why I say that these approaches look like complementary to us. So we are not doing, we have not yet presented a synthesis of areas done because we are still waiting for a certain number of countries done. But right now we are following the data that is coming from the countries and providing feedback to the countries. This data is examined weekly in IVD, weekly in the IMS team meeting, incident management support team with emergency. It is presented, the countries are present and decisions are taken, feedback is given to the countries. So those approaches are helpful to our region also. Now, what is novel here is the approach that you have used, the qualitative analysis from the IR report. So I will be very interested to see more details how this is carried out. I can understand that from some individual IR reports, you might not get like things like root analysis and what are the root causes. But when you bring the different reports together, I am sure you can pick out some things that could be applicable to many countries. So I find that approach interesting and maybe helpful also to us. Thank you, over from my side.
Thank you very much, Emmanuel. I think that was very helpful. Roberta, maybe I can come to you next and say that, so you presented, something that was maybe slightly less intensive and or less resource intensive and less time consuming than the classical mini-pies. Having listened to the other presentations, do you see a particular role for conducting mini-cPIEs, at least in some of your countries? And when would you advise that they move to conducting a mini-cPIE or even a cPIE?
Yes, so this is an interesting question. And as I said, even in the presentation, it is important for us to understand what are the outputs and outcome of this light approach. Of course, an in-country mission with assessment also of the implementation of the campaign at field level brings a lot of value and a lot of additional information that cannot be collected through this light approach. But understanding when is the right timing and which are the right countries depend a lot on the country willingness to conduct this exercise and really take on board the effort that is needed to conduct this Mini-cPIE and EIR and take on board the recommendation and really implement the recommendations coming from this type of exercise. So I think that the country commitment and the country willingness to conduct this exercise is the primary driver to define whether to switch from this light approach to a more intense approach. I think for the time being, this light approach in Euro is working because then in-country missions are mainly focusing on providing support in areas that are identified as priority areas. So by providing that support, sometimes the support is given in a way of having a more in-depth assessment of the specific area that has been identified as critical in progressing in COVID-19 campaign. So I think vaccination campaign. So I think it's really depending on country willingness and to conduct an EIR, and also what this type of light approach can bring in terms of focusing on the solutions instead of the assessments. Yeah, maybe one thing that I wanted to say is that the difference between overall engagement with countries during the COVID vaccination and the routine immunization is that with COVID vaccination, there has been a lot of very frequent contact with countries. So there are a lot of weekly meetings that happen with partners that have a footprint at country level to understand what are the ongoing challenges. There is a lot of close monitoring of the progresses. There are forums that are set up with groups of countries with coordination through hubs that really allow a kind of continuous monitoring of the progresses and challenges, which is probably missing for the routine immunization. So I think it's also important to consider this type of routine light engagement with the countries to understand whether a more in-depth engagement is needed or not.
Thanks, Roberta. Yeah, I think you're very right that there is a lot of a constant dialogue going on, especially with the countries that seem to have issues that, and so I think one needs to look at the incremental benefit of doing a full IAR in such countries. But if I can, I'm not sure if Alba Maria has access to her mic, but if you can check, Jenny. But meanwhile, if I can ask Sheila, I know that in the African region, you have now progressed from going from the IARs to actually conducting country missions with having more intensive discussions. And also during those country missions, actually doing direct observation of vaccination activities in select sites. To an extent, this becomes almost similar to conducting a full cPIE or a full PIE like we did for the other new vaccines. So if I can ask you a few reflections on how the IAR reports may sort of assist in designing and focusing on the key issues when you conduct these country missions or the full cPIEs. Sheila,
Pardon, sorry.
Sheila, could you hear me?
Could you kindly repeat that, please?
Yeah, thanks. Jenny, I noticed we have reached the end of the time. Can we continue for 5 more minutes or are we closed?
I think we can continue for a few more minutes, but we will unfortunately lose our interpretation. If I am correct on that.
Okay, yeah, no, Sheila, what I was asking you was, since Afro has now initiated the country missions, the extent to which the IARs could help focus these country missions on the key operational challenges that the countries are facing.
Thank you, Thomas. From the IARs conducted, there were key bottlenecks that were identified. And so this is like a starting point for the mission teams to engage with the different countries to understand how these bottlenecks have affected the rollout processes and if some of them have been addressed. But also starting from the recommendations of the IAR, the mission teams are finding out if the countries have actually used the recommendations from the IARs conducted to improve the rollout processes. So the IARs conducted have been helpful in pointing the mission teams to where they need to start from in engaging with the countries.
Thanks a lot, Sheila. Is Alba Maria able to join the call? Use her mic?
Yes, this is Alba Maria. How are you?
Hi, Alba Maria. Do you have anything to add what the colleagues have already said? I'm not going to pose a specific question.
Thank you, Thomas. Thank you for all the Thank you for all the presentation. Let me see that I am. Thank you for the presentations and the experiences. We are learning a lot from you. You are very well advanced in these exercises. We are in an earlier stage here in PAHO, but with some experiences, I would say that we have similar findings with the Mini-cPIEs. But I like the approach that Europe is doing now, trying to have a lighter approach and a faster approach in order to identify gaps and also to recommend actions to improve the situation for the rollout. Thomas, I would like to have a discussion with you, for example, with this software as well, in order to see to use it here at PAHO, and that will be a nice conversation based on this experience that you are presenting here. That will be, I think, that will be very useful for us. The main issue here that I would like to highlight also that somebody mentioned as well was the interest of countries to conduct this kind of evaluations. Independent of the methods, the acceptance of the clearance of the country or the interest of the country conducting these evaluations, it has been a bottleneck for us. But we are making some progress, and we're having some countries already in the stage of planning these evaluations. We conducted Bolivia already, and we are in the next step to conduct 2 more countries. But this is very useful, and I think that we can combine different methodologies, and having lighter approach would be better because they are very busy, they have many competing priorities, and then if we have a better and simpler methods, that will be better for the countries. Thank you so much for the presentations and experiences. Over to you.
Can I ask you a follow-up question, Alba Maria? And maybe Roberta also, if you want to add in. Would sharing some of the lessons learned from actually doing a Mini-cPIE like we have done now be an incentive for any country to actually take the time to do a Mini-cPIE?
Yeah, that would be nice to have to share more those experiences, and then they can express or they can see the importance of having this kind of evaluations.
Roberta, you want to add something?
I also think that sharing experiences from countries that have conducted a Mini-cPIE can be an incentive for some countries to conduct a more in-depth exercise. I wouldn't see any harm in that. It will definitely be interesting, and it can also be a good way to inform partners on common challenges and maybe have a better coordination on which areas need support from external resources. One caveat, I'd say that maybe the findings from the PIEs can be stratified by income level, because we see that challenges of countries in different income group often change quite significantly. So countries might not be that interested in hearing the results from a PIE that is conducted in countries with a very, very different context. So maybe this is something that can be taken into consideration to stratify the findings and share the experience with a homogeneous group of countries, at least by some criteria. Income can be one, but it could be other aspects.
Thanks a lot, Robert. I think that was a useful comment. If I can ask Jenny one last question to Emmanuel before we conclude.
If the panelists are available, we can just take a couple more minutes and then we'll close up.
Okay. Yeah, Emmanuel, I think in your region, we know that at least 2 countries want to go ahead and do a full CPIE, or maybe more than a few countries want to do a full CPIE. That is with an independent team being there in country, going out, doing field visits and observations. So what was the trigger that made these countries decide to go, or at the regional level for you to decide the time was right to do a full CPIE? And could we use your experience in CIRO to then maybe also advise other countries on what is the optimal timing to do a full CPIE?
Yes, Thomas, we have, as you mentioned, 2, now 3 countries which have notified their plans to do a CPIE. Their approaches that they are taking will be a bit different. In Bhutan, the CPIE will be done virtually. In India and in Maldives, this is going to be a mission in the field to do observations and all of that. Now, what the countries have taken this decision, let's say, more or less independently. Now, Bhutan has done a Mini-cPIE, of course, and they want to follow up with a full CPIE, so it is understood. Now, what we understand from the country's decision, they looked at issues like coverages, where they are with the vaccination coverage, and sometimes they feel that their coverage is high enough for them to do a full PIE. All our countries, of course, are beyond 6 months of implementation right now, so that is no issue. And instead of doing a Mini-cPIE, they think they will benefit more doing a full PIE. The other issue is the resources. So things have been discussed around financial resources and around human resources. So these countries have thought that they have their resources are not available to do that. Now, I will say that in contrast to some countries that have decided that a full CPIE will be done next year because they are looking at the country situation. The COVID situation transmission is still high. Their personnel is involved in vaccination or catching up persons who are not being well vaccinated, and they don't think they can mobilize the personnel to go to the field to do this activity when their interest right now is to reach the population. But for this particular countries, they think they can consecrate their human resource and the finances to do now. The other thing that we are looking at, of course, is the situation of COVID transmission in the country. So in India and in Maldives, it is possible now to travel and go to the districts and interview persons, of course, with all the precautions that are necessary. And I mentioned that in Bhutan that wants to do that, where travel restrictions are still there, they decided to do this virtually. Thank you.
Thank you very much, Emmanuel. I think that was very helpful for you to lay out the different conditions that need to be in place for you to do a full CPIE. And I know that Jenny was very interested in knowing what those factors might be, and I think your response was very helpful. So I think we'll stop the discussion here. And Jenny, back to you.
Thanks so much, Thomas, and thanks to all the presenters and panelists. Yeah, I think this has been a productive conversation and helpful to have some inputs on how to best use the analysis, how to make this kind of analysis useful at the different levels, and thinking about the ways to use the different review platforms, adaptations to the Mini-cPIE, and this idea that countries really have various factors to consider, whether the best choice is a Mini-cPIE or an even lighter approach or the full cPIE. I think that 6-month cutoff obviously is not the only consideration for when to move from a Mini-cPIE to a full cPIE. So thanks so much for all your contributions, and thanks for those who have remained on. I know we're already more than 10 minutes over. We could just run through the final few slides that have some resources for the audience. We have a Mini-cPIE Telegram group that you can join using this QR code, and we'll make the slides available after. Next slide has just the notice about our next Mini-cPIE clinic. So this is focused on country experience sharing, and that is going to be on November 23rd. And the registration link is already available here. Next slide includes resources on IAR in general, which is the ones on the left, and then the vaccination-specific Mini-cPIE tools. We include our Mini-cPIE clinic materials where we have all the country-focused presentations on this last link at the bottom right. And I think next slide, we have some additional updates on the costing financing series that this session is a part of, and maybe I'll just hand to Angela to wrap up.
Great, thanks so much. So our next session is the health workforce and how to address bottlenecks. It builds on a health workforce session that we had in the first series in the spring. Stay tuned for that. And the subsequent few more series after that through to December is also on the registration. I'd like to point you to a December 1st ECHO session on data, all things data, COVID and COVAX. So we have a number of really good speakers lined up and some availability of new data that complements what we talked about today. And also flagging one more session that rounds out the end of the year, December 15th, which recaps kind of the year in review, as well as looking forward to 2022. All those are on the ECHO session website for registration, in addition to the ones that Jenny has mentioned on the Mini-cPIEs. With regard to the last slide, any questions related to the session topics that aren't answered will be shared through technical experts and through email. I know our interpreters have probably left, but always a gracious thank you to the ECHO team and the interpreters for their wonderful work. Thank you everyone for joining today, and we appreciate seeing you. Have a good morning, afternoon, and evening. Cheers.